Hi, I'm Dick Vermeil. I've seen a lot of good arms over the years, but Frank here has a really good arm. So does Carla. Louisa's got a great arm. Marcus, too. Everyone in our region has a great arm, capable of defeating COVID-19. So get your vaccination when you can. They're safe and effective. It's been a challenging year with times of anxiety and loneliness. Together, we can make this the greatest comeback win in Philadelphia history. We'll beat COVID-19.
The COVID-19 pandemic has meant unique professional and personal challenges for women in healthcare. Severe burnout can afflict up to 33% of critical care nurses and 45% of critical care physicians. Women, who make up 70% of the health workforce but just 25% of leadership roles, have less power to make changes. Childcare burdens fall more heavily on women and are prompting many to consider leaving the workforce, and women of color face added pressures. Today on Inquirer Live, our expert panel of healthcare professionals share their own experiences treating patients and working with colleagues over the pandemic, and also look ahead at the future of work for women in healthcare.
Hello, everyone, and welcome to today's Inquirer Live Health Report. I'm Charlotte Sutton, the Inquirer's health editor, and I'm so pleased that you're here with us today for what promises to be an important conversation on women in the healthcare workforce now and in the future. A bit of housekeeping first. Though we are streaming on several platforms, if you would like to submit a question, you'll need to go to our webpage. The address for that is inquirer.com/healthreportlive. And with that, I'd like to quickly introduce our panelists. And I've asked each to talk for a few minutes about their experience of the pandemic before we start our conversation altogether. I'm going to start out with Dr. Resa Lewis, who is an emergency physician at Thomas Jefferson University here in Philadelphia. She also is creator and host of the Visible Voices podcast, as well as a contributor to the Inquirer. Amie Archibald-Varley is a registered nurse and the quality and patient specialist at Niagara Health in Hamilton, Ontario. She is the co-creator and co-host of the Gritty Nurse podcast. Suzanne Chong, PhD, is the staff psychologist at Ursinus College outside of Philadelphia, and she also is the founder of Clarity and Insight Counseling Services. And finally, Natalia Ortiz-Torrent is a psychiatrist and the medical director of consultation and liaison psychiatry at Temple University Hospital. So let's start with you, Dr. Lewis, if you could share your experiences of the past year.
Thank you, Charlotte, and thanks for this invitation. It's really great to see everybody on the panel, and thanks to all of you who have joined as audience members. We were asked to sort of reflect on our experience personally and professionally, and I'll start with professionally. 2019 going into 2020 was unlike anything we had ever experienced as emergency physicians. No matter where we've trained, it's a small community such that we heard what was happening in the Pacific Northwest, in Seattle and San Francisco. We knew and heard what was happening in New York City. And I think for many of us, February going into March, going into April, a year ago, there was this anticipation and this difficulty for many people to sleep and to concentrate because of the anticipation of a wave that was coming from New York City. We were speaking with our colleagues in terms of patients that were coming into the emergency departments, the level of illness, the level of distress, respiratory distress, the intubations, and the portable morgues. So it was on our mind. The messaging that was happening for us within the hospital system was pretty nonstop. We were getting messages, we were getting policies, we were getting updates. So I particularly remember the feeling of having to always read and make sure I was reading and what was up to date and reviewing procedures, reviewing medications, and sort of this stress of being up to date and having to pivot on perhaps what one's previous knowledge was something we'd never experienced before. Mm-hmm. In the actual emergency department, PPE, donning and doffing, Many of us, we do that once a year and get checked off, or maybe you do it in medical school. Maybe you do it when you're in the intensive care unit, but it was never something that we were routinely doing on shift. And I remember a particular feeling of difficulty remembering, how do I put it all on layer by layer? How do I take it off? What's the correct way? And we're all pretty much rule followers. So there's this feeling of, wanting to do it right. Our actual department shifts changed. We went from working shifts in the emergency department to doing a lot of telemedicine shifts. Mm-hmm. Urgent cares closed. So the assortment of shifts and where we were assigned to work and take care of patients changed. Mm-hmm. Personally, I overall feel that I was very lucky to have work that made me leave the home, such that I was able to have social interactions at work, although beneath PPE. Mm-hmm. I also enjoy quiet time and alone time. And actually, I think it's a bit of a reaction to working in the emergency department, which is so much information and sensory overload, such that I got into some routines and rituals, made sure I take a daily walk, meditation and yoga regularly. Those types of things, I think, allowed sort of a physical, mental, emotional clarity to tolerate and withstand what was happening, because I think there was always this sense of not knowing how long all of this was going to be going on. And I'll end with just a final piece about the podcast, and I really appreciate the mention by Charlotte. I had been working on podcasting and hosting and interviewing for years, always under someone else's platform. It was because of COVID-19 and the acute on chronic exacerbations of structural racism that we witnessed that I decided it was time to launch a podcast with the intention of amplifying voices, some that are known, some that are unknown, but covering topics of healthcare and equity, specifically because of just the acute, piercing moment that was 2020. Mm-hmm. Thank you.
Thank you, Resa. Amie, can you tell us about your, I shouldn't say year, 16 months?
Yeah, for sure. And again, thank you to everyone and the panelists. Thank you for having me today. I think if I think about myself professionally, how the pandemic has affected me, I think for nursing, it's been a little bit of a wild ride. And I fortunately was a little bit more removed than some of my other peers, which led to actually a lot of guilt. So as a quality and patient safety specialist in overseeing the emergency departments, my role was really to help with quality improvement measures. And then I also had the added pressures of the infection control portfolio. So it just came it seemed to all happen very quickly, because I remember, February 2019, 2020, and it just went from one day of us, talking about, oh, we're seeing it here in China, we're seeing what's happening in New York, and then it was here in Toronto. And I can tell you, I don't think we were ready for it. Although we saw what was happening in other places, we faced the same challenges that other countries faced as well. The shortages of PPE, seeing some of my colleagues in Quebec wearing plastic bags to protect themselves because we had shortages. The fight almost sometimes to have adequate PPE, using the precautionary principle in terms of, we don't know what we're dealing with. Should we be using N95? Should we be using simple surgical masks? And then just watching some of my nursing colleagues who were working in the ICUs burning out at alarming rates. I think for me, that was some of the most challenging things that I saw, some of the most difficult things that I saw. And then I think for me, the other biggest part was having a colleague, wasn't close, but a colleague nonetheless, another nurse that died by suicide. And I think that's where it was a turning point for a lot of nurses in the profession related to COVID-19, knowing how stressful, knowing the burnout, knowing the additional stress that we had as women in the workforce and how crippling it actually had been. From a personal standpoint, again, I'd say it's been pretty wild. I have 3 children. I have 2 twin boys that are 9, and I have a daughter that's 6. And obviously, with what happened was when the shutdowns came, that was 3 children that I had to homeschool. So although my husband was working from home, and then I ended up starting working from home, we had 3 children, all in different classes, having to homeschool all 3 of them. And then the added pressure of having both of my twins have special needs. So a son with autism and a son with ADHD. So I had all of these other things that I had to account for. And like Resa said, for me, the podcast was like the silver lining. It was my ability and my time to talk about the things that I've seen, talk about some of the systemic challenges, talk about the poverty and inequity that we were seeing related to COVID-19. And it, for me, was one of the largest outlets that I had. And I was very grateful for myself and Sarah to be able to talk about these issues. But I'll kind of leave it there.
Okay. Amie, thank you so much. Suzanne, can you share your past 16 months with us?
Mm-hmm. Hello, everyone. It's very touching and just feeling a lot of just hearing what you have shared. And that resonated with me. You know, in my professional life as a staff psychologist for college students, and you know, coming from the mental health perspective, where we recognize that the college experience should be a rewarding and unique one. And because of COVID-19, we have to implement a lot of restrictions to protect our students' health. Also being well aware that some of the restrictions that we're implementing, like the social distancing, you know, like isolating the rooms and doing remote classes, we also is very acutely aware that it is affecting their mental health. Like the things that are supposed to enhance their well-being, their feelings of satisfaction and happiness, we're seeing that all these supports are being taken away, right? And we can talk about students' mental health in a vacuum. It's just not about enhancing their quality of life as a student. We also recognize that they're part of a family system. They're part of the community. So in my past 16 months, just working with students, sometimes, you know, academic challenges have to take a back burner because we're just fighting fires. You know, they're sharing with us about how the challenges that their parents are facing. They're talking about family members being ill and feeling very helpless about it. So from a professional standpoint, like what Resa said, everything felt very new. You know, the things that we're recommending typically to improve your mental health are things that we have to be very mindful of, that it might also be detrimental. There might be consequences. So it was a lot of just having to work as a team. And professionally, I also feel very lucky that I am at an institution that is very understanding. There's definitely a lot of flexibility of being able to work from home. So we transitioned to telemedicine, to telehealth. And for some of our students, that actually did, you know, indicate a significant improvement because of the flexibility. We did see, you know, less no-shows. In fact, that was the reason why it prompted me to kind of start my prior practice, just realizing that when I removed the challenge of the geographical location, I was able to provide access, you know, maybe more equitable access to a wider number of the community members. I think that was helpful. Of course, it's not a perfect system. You know, we still have to be mindful that there are members of the marginalized communities that don't have access to the technology that we're utilizing right now. But, you know, that was a welcome change to recognize that, yes, we can still pivot and adapt. It's very challenging, but it's possible to find solutions. And personally, it was something that I've been reflecting on, thinking about. I do have a toddler. He just turned 2 a couple of weeks ago. So we were planning to put him in childcare and preschool. And of course, the shutdown happened and we all started working from home. And for a while, like my husband and I had to juggle between looking after him and going in without work. And what we did was, you know, just by happenstance, just by luck, my husband is on research sabbatical this past semester. So he was actually able to work from home and be there for our son, while I was constantly just having back-to-back sessions with my clients. But I know that not a lot of families have that opportunity, unfortunately. I think that inequity and that lack of standardization has really affected a community.
Thank you so much. Natalia, if you could round us out here, and then we'll start our conversation.
Thank you very much for the invitation. And these are very powerful stories. I can really very relate with everything. So personal experience during the pandemic, very different than my experience through multiple hurricanes that I survived in Puerto Rico, and the experience that my family had in Puerto Rico, but Hurricane Maria. Back in Puerto Rico, we get prepared for hurricanes, but not for pandemic. That's never heard. During the pandemic time, I was here in Philadelphia. My mom had moved with me. She's 86. My sister, my niece, who's 8, they moved after the hurricane to live with me. So I was very scared. The type of psychiatry that I do is in working in the main hospital, medical surgical hospital. So I was, since we didn't know much, I was concerned about being a carrier and passing the virus to my loved ones, specifically, my mom and my niece. So my routine was to get, luckily I had finished the basement just not that long before the pandemic, and I had set up as a small apartment. So I was able to live there and get meals delivered by my family. They put it on top of the staircase and eat them. And we communicated, by phone and technology. We watched movies together, shared the screen. So there was it wasn't the same, of course, but I felt calmer because I was concerned about transmission. Then after that, we start learning more and, wearing the mask in the house, distancing, or sharing the utensils. So we were able to coexist, to live in the same environment with distance. It was strange for a Latino family. I'm sure we are hugging and kissing everybody. So it's a challenge. So as professionally, I was, obviously working, directing a program to take care of the mental health of the patients, seeing way more patients. Clinics were closed. Some transition to the video, but not all the patients had the ability. So some of them, they had a phone, they transitioned to phone calls. Then, changing policy. Seeing patients that have COVID-19, we use telepsychiatry to do that, to serve them and serve the primary teams. Got involved in some initiatives through some other organizations to educate the community in Spanish because there was a lack of that. And we partnered with some organizations. And eventually we did more work with the vaccine hesitancy, with other groups, and addressing and doing community outreach. That's the way that I cope by trying to help. But I kind of neglected my own self-health. So the other things that I had, that I was reminded of, my body reminded me, and I had to take care of me, to take care of others as well. So learn experience. Thank you.
Okay, thank you. That's a great reminder that you can't take event. What do they say on the airplanes? Give yourself the oxygen first. Speaking of which, let's start out with a topic that is familiar to a lot of people, not just those in healthcare, but and that is burnout. I think that the statistic that we cited at the beginning in the video, those were actually burnout rates from before the pandemic, and I have to believe that it's only gotten worse. But my question for all of you is, generally speaking, burnout in healthcare, is this something that is just, it's just the way it is, nothing can be done about it? Or are there, are there certain factors feeding it that with better policies, better leadership, better programs, we could be dealing with that so that, you are all more able to care for the people who are really relying on you? Anyone, please jump in.
I would say that the body system, getting connected with either your department leadership or you directly with the colleague or a friend, just checking on each other to see how we're doing. We don't have to open ourselves up if we don't feel comfortable, but just checking and having a conversation. We started the wellness program through the Latin American healthcare professionals, and we learn new things in different areas of wellness. But what was more powerful? Just all of us getting together, even through camera and talking, bonding. That was helpful. Flexible schedules, we did some of that. Transitioning to the telemedicine, that helped, but the back-to-back appointments were overwhelming. At times, the appointments were overwhelming. And then, things that you mentioned, I went for walks and discovered there's so much wild nature, beautiful plants, beautiful animals I've never seen before. I guess because I never took time to do that type of, walk. I think that helped. Exercise help.
Yeah. Suzanne, you and I talked. One of the things that I've wondered about, Suzanne, you and I talked about how challenging it is when you, on top of a pandemic, on top of everything else, we then have hate episodes, violence. People, especially in the Asian American community, being targeted. How did you deal with that particular aspect during the pandemic, but both for your clients and also for yourself?
Yeah, that felt like, as an immigrant and Asian American woman, that is not, like when it started happening, it was almost like we were anticipating it, that it will happen, right? It was something that we have in a lot of ways lived with, that has never been really talked about. It's almost in some ways accepted that this might happen. Someone might see you as an other and might treat you as such. And someone is going to target you just because you look different, and that they have to share their rage and anger on perhaps with the stereotype that you're not going to be able to fight back, or that you're just going to take the violence and the aggression and the vitriol. So when it really became hard to ignore, let's just put it that way, right? Navigating it as like, okay, do we have to always talk about it? Do we always have to be concerned about it? Do we feel powerless when we even talk about it? Are people going to listen to us? Are the media going to take us seriously? Are the legislators going to take us seriously? It got to the point where what I think was reassuring to me was that this collective voices that kind of came together, I think to me that was helpful. Like the crimes were horrifying, the videos were hard to watch. No, I don't watch them if I could, but to hear this collective voice saying that this is unacceptable, this is enough, and then that allowed that space for us to just have open conversations about it, for people who have never really shared their stories of harassment and assault to come forward and say that, yes, this is happening. And then to see also the positive changes happening, I think that was really encouraging.
Interesting. Yeah. So, I mean, are some of these issues that the pandemic laid bare, the racism in particular, the sexism, all of this, certainly they were there beforehand. In a way, has it been helpful to have it, become so obvious, or is it just even worse? Amy or Resa, if you want to. No, go ahead, Suzanne.
Oh, I was just going to say that, for so long, if we're talking about sexism, like maybe right before the Me Too movement, even when I was in graduate training, the way we talk about how women should present themselves in a professional force, right? It was like, oh, you got to dress a certain way. You got to look a certain way. You got to act a certain way. It was so normalized to tolerate that and kind of like internalize that. And then we're getting to the point where people are saying, no, we don't want to do that. It was the same thing with racism. I think for a long time, we were told to just like, if it's not a big deal, let's not make it a big deal. If it was just a slur, we can ignore it. It's fine. We can move on from it. We should be grateful. We should not, so a lot of it was just like, let's normalize it. And then I always think about how like, when we start normalizing these little episodes of injustice or being made to feel less than, then we are allowing that space, that line, that boundary of what is acceptable and not acceptable to keep being pushed, right? And that's when, if I have to be a little bit more morbid, right, that's how perhaps genocide starts. You know, that's how ethnic cleansing starts. So I think having a conversation about it, it's helpful. It's painful though. Feelings are real and valid, but probably also necessary.
Yeah, maybe if I can kind of jump in there too. I think one of the things that the pandemic has revealed are those structural inequities and those systemic forms of racism that, you know, we don't necessarily talk about in healthcare, but we do. But we actually need to talk about them. So one of the things that I noticed specifically was, you know, we learn about the social determinants of health, but we were seeing it in full action. So we were seeing people that were at the poverty lines, people that were precariously housed, marginalized communities, racialized communities. Black females tended to be heavily and more affected by the pandemic as well. And we were seeing these types of people in the emergency departments, in the ICUs, and it was undoubtable. You could not turn a blind eye to seeing that there were some structural and institutional things related to racism that were happening in our hospitals related to COVID-19. And, you know, I think when I think back and I think about, you know, the death of George Floyd, to me, I feel like that was one pivotal moment, but this was something that many other Black folks were talking about for a very, very, very long time, right? Like, I cannot get out of the skin that I'm in, nor do I want to, but I do want people to realize that there are differences in the way that I might be treated versus someone else. And I think through the pandemic, it has revealed some of these structural changes. But then again, we're still, I feel there's a lot of education and a lot of combating to do. So like, for example, right now in Canada, we're seeing all of with residential schools. So we're seeing all these children being essentially that were buried next to schools being revealed. And it's kind of like, well, we need to talk about these things to see how we can change the future of healthcare. And I think that, you know, it's not an easy conversation, but it's one that needs to be had.
Amie, can you expand on that a little bit? Because, you know, I think a lot of people persist in the belief that, you know, hospitals are, you know, places where everybody goes and everybody's treated the same and everyone, you know, gets fixed up. And, but can you expand a bit on what you mean about how some of the patients, their care revealed some structural racism?
Yeah, I mean, this is one of the things that I would say, you know, I've had conversations with other physicians too and other nurses when we talk about things like something simple as like pain. Pain is what the patient may say it is. So, you know, a patient may come to the emergency department and maybe based on their ethnicity or their background or something that could even be documented in their chart. It could be just something that, you know, history of alcohol abuse or whatever the case may be. These small things can change and alter the way that that patient may be cared for in the healthcare system. But again, we have to look at, we can't turn a blind eye to the way that, you know, Mr. Smith comes in and then, you know, another Indigenous folk or a Black folk might be treated when they come to the emergency department. And we have to call these things out. So there are many stories in the media. Just recently, there was one of an Indigenous man who came in complaining of sepsis complaining of pain. And essentially he sat in the ED waiting for 4 to 6 hours, not being reassessed, and then died of sepsis. So, I mean, these are things that we can't turn a blind eye to. And I always have to say, we do need anti-racism training. I think I know training is not the be all and end all, but it is to start the conversation to say, you know what, there are viewpoints, whether they are through hierarchical thinking, systemic racism, you know, that kind of racist power that's passed on and these racist ideas that are passed on into medicine that you know, make us act in a certain way. And the thing is, we need to look back and say, okay, how can we fix this? And we need to have policies and procedures that reflect anti-racist ideas, specifically for Black and Indigenous folk as well.
If I may add, I think the concern is that people's memories are going to be brief and short. The extreme circumstances over the last 16 months didn't give hope and light, but if we were to look for hope and light, it's that what can we learn, what can we change? And Charlotte, your question about burnout, your question about the systemic reveals, the concern is that nothing will change, and that what we're going to take out of this is going to be getting, a virus that sort of got out of control, and then once we get it under control by whatever means we decide, people are going to forget what was revealed. And I'll just use an analogy. In the emergency department, we're back to ED crowding. Everybody hears about crowded emergency departments. We're back. They're back. Mm-hmm. Whereas we were able to work collegially with other specialties to actually remove that ED crowding. It sort of went away in many hospital systems across the country because of the commitment to patient care, the commitment to keeping the portals of entry clear. And now we've regressed back. And there are a lot of, it's not as simple as like, it was a decision. There's many more people are now coming to the emergency department. But I think in a similar sense, there's a concern that people are going to forget these instances, such as Mr. George Floyd, and which was not the first incident of someone being killed by police. This has been going on for decades, and all of a sudden people are aware. Great. We love that awareness. But I love books. I'm a big reader, but a book club is not going to solve this. There's so much systemic in healthcare, structural in healthcare, that causes the burnout, that causes the social determinants of health, causes the racism, causes the sexism, causes the harassment. And we're at a pivot point of opportunity.
And
No, go ahead, Suzanne, please.
No, I was thinking of that. I agree with that. And maybe because I was just reading about how we're still talking about how there is a shortage of, medical professionals in healthcare. Like there's been a shortage before the pandemic. There's a shortage right now, and they're expecting an even greater shortage after the pandemic ends, when burnout becomes a real issue and people have to leave to take care of their health, right? So it got me thinking, when I hear about my fellow colleagues from different fields, licensed clinical social workers, psychiatrists, medical doctors, nurses, about what goes, like how much giving we have to give, and especially of women and maybe even women of color, how much we have to give to kind of bend to the institution to make it work, right? And then to hear the internalized message that, oh, you do need to suffer, you have to get into a lot of debt, to complete your medical training or professional training, and then to tolerate the long hours, just because it is part of the rite of passage. Yeah. So part of it is really like a deep introspective and systemic and also institutional look into how we are actually challenging the ways we have always done things. And I think that's like the most scary message, and maybe the message that hinders a lot of change, is that we've always done it this way, and this is the way we should do it from now on. So I don't know, so maybe there should be some policies. And also another thing I want to bring up, and this was the statistic before the pandemic. I don't know how it is so far, but currently in the field of psychology, and we're talking about counseling psychologists and clinical psychologists, only 5% of Americans, of psychologists are actually Black Americans. And I think maybe less than 3% identifies Asian American or Pacific Islanders. That is kind of a travesty. So we need to question why, in terms of even access to equitable care, and maybe even like being able to enter the medical field. We are definitely seeing this difference in racial and ethnic groups and cultural groups entering the healthcare system.
Yeah. Resa did a wonderful interview that was published in the Inquirer a few days ago that I think I want to bring up a quote from that was really germane to this point. This is an interview with Vineet Arora, who is the Dean for Medical Education at the University of Chicago's Medical School. And she said, quote, We've seen a lot of Black women exit academia. I shudder to use the phrase by choice, because usually, if you peel that onion, it's usually due to decades of microaggressions. How does that comment land for all of you?
Maybe I'll start. When I think about it, and this is me from taking a page from kind of How to Be an Anti-Racist. When I think about the term microaggression, I do think of it as racial abuse. So if you think about, there are all these small little acts that, whether it's someone clutching their purse in an elevator, or, someone giving you the wrong look, or, I raise my hand in class and a white peer besides their question gets answered before mine or whatnot, or, the overlook from that representation where, I might be the only Black individual that is on a panel or whatnot. I think that all of these little forms, which we call them microaggressions, are actually small forms of what we would actually call racism. And I think we need to start calling it out as we see it, right? And I think this is probably one of the most difficult aspects, because we have to think about what those small acts continue to do to someone like me or someone who might look like me. And every single time it hurts, right? These little abuses that continue to happen affects people's mental health, affects the way that they think and perceive the world, affect the way that, even thinking about, could I be someone who could be in the medical career? And I look around at my peers and say, well, maybe there's not anybody here that looks like me, so this space isn't for me. I think this is where policies and procedures are so important in terms of informing them from other lenses. There's such a wide diversity in terms of the people that you can speak to get experience from, but sometimes we're just not seeking that out, particularly in medicine and in healthcare. And this is where I would say to others, like, you have to ask. Sometimes it's just, ask that other person to say, like, what is your perspective on this, and get their kind of their lens.
Mm. And how is it that being a woman exacerbates those acts of racism, which seems to be the point that this physician was making?
I think this is where you look at all of the term intersectionality, right? So the various different factors that may play, and being a Black racialized woman just kind of, in terms of the intersectionality, almost puts me right at the bottom, right? So you have to take into account all of these different factors, and it just makes it much more harder for a racialized Black woman to kind of break into these spaces. And this is where we talk about seeing it from an equity lens. So not just from equality, but how else can we, what other strategies or policies or things we could put in place to help build someone up like me, to help put me in a place where I would be not just disadvantaged, but advantaged, have a better opportunity to see myself in these different roles.
It's a great point.
Yeah. I agree with you. For many years, I was in social isolation, because I believe what many people said, not necessarily on the field, but outside the field. And we're not talking about patients here, that they said, oh, you have to go back to your country because I have an accent. I still have it. It was obviously more pronounced. So, and I start believing that the getting what they call the imposter syndrome, I don't deserve more. I had to work hard, demonstrate, and work extra hours, take extra shifts. So that was my experience. But luckily, I explored, and I had a mentor in residency, a female mentor, not Latino. Sometimes you find mentors in the most mysterious ways. And the person that you don't think is going to be a mentor, that's the person that kind of identifies a characteristic in you that you don't see, and empowers you, helps you. So I think, and that through the years, I have found several mentors. I've been surprised at the mentors that I found. I'm very grateful to them, and helped me to move from not believing to believing, and being able to move forward in leadership roles that I never believed that I was able to accomplish. So I think mentorship, sponsors, programs or no programs, informal, formal, very important for women.
So the leadership needs to be just more diverse. I think that's just how it has to be. And that's where the institutional change can start, you know. And just like what Amie has shared and what, you know, Natalie has shared about how sometimes these beliefs are so ingrained that one way that we could actually implement some change is that maybe we have to be more proactive and intentional in who we put at the leadership board. And the intersectionality of misogyny and racism, they're not entirely separate, you know. And adding to the fact about, you know, Black women in academia leaving the force faster than ever, I also want to bring up a point that students, you know, college students going through college education are sometimes harsher on professors and faculty of color, you know. So the ratings that professors achieve, and again, these are very implicit. It's very hard to call out on, you know, but sometimes, like, it's noticeable. Like someone could be teaching the exact same course with the same materials and might still get a lower evaluation. And actually, studies have shown, you know, repeatedly that if you're white and male and you're in academia, your ratings are generally better. If you're controlling all the factors, it still comes out the same. So it's not just about, like, you know, dealing with, quote unquote, our colleagues and leadership. We're dealing with the entire society as a whole of how we're being perceived. And that impacts how we feel like we're being accepted, appreciated. Like, we just don't need to be seen as faces of diversity, but we really need to be at the table, be able to make decisions.
Absolutely. You know, I'm thinking back to a while ago when Resa and I first started talking about the topic of women in healthcare. One of the things we were both noting was that, you know, there's been all this talk about women leaving the workforce because of the childcare issues. And Resa, you made the point, I was like, no, a lot more than that. Can you talk a little bit more about that?
Thanks for that question. So if anybody is at a job, working in a profession where they feel valued, where they feel respected, where they feel they have a voice, they won't leave. They won't leave. And so what we see is when women leave, it's very convenient to say it's because of children, they want to be at home. Oh, it's because they have aging parents, they want to be with those parents. Well, so first of all, those all may be very, very true. And also, it is fully possible to create work environments where women can lead, women can excel, women can have ambitions, and have their full lives at home, whatever that full life looks like. And so I think when we hear that, it's often of convenience. And what is going to come out, I believe, in the literature from the last 16 months, and some of it's already out, fewer women as first authors on publications in healthcare journals, increasing incidents that are reported of sexual harassment. And this is sort of the onion that Vinny was speaking about when we spoke and had that interview. There's so much more to it. The salary disparities, which were well documented before the pandemic, you know, 80 cents on the dollar, and add on intersectional identities, 60 cents on the dollar. I mean, ludicrous for doing the same exact work. This is not new. And when I first started really looking, learning, speaking, writing on in the equity sphere, I was surprised at how much data is available. There's so much available. And what I believe is what comes out of the last 16 months, it's going to be even stronger, some of these disparities. And, you know, going back to being solutions and having hope and light, it is upon us, and not just us alone, but people in leadership that have power to make changes, to write different policies, to select different co-leaders by their side.
Well, you know, in the last few, the time that we have left, we have about 15 minutes. Why don't we talk about what would be some potential solutions? Amie, I was very struck the latest episode of your podcast. I too am in a profession where pizza is often given to make us work more. So for those of you who haven't heard it, the latest Gritty Nurse podcast is called "The Pizza Just Won't Cut It," hitting the reset button on how we think about nursing retention. I think retention is a huge issue across healthcare. So why don't we talk about, what could be some real concrete steps that women could actually lead in terms of dealing with this retention issue?
This episode was actually so timely because we were seeing actually in Alberta, they were talking about a rollback of the pay that they had given nurses in terms of during the pandemic, that they were actually asking for 3% of their wages back. And myself and Sarah were just like, oh my goodness, like that's not, we're already hearing that younger nurses who are early on into their career are thinking of leaving the profession. Retention's a conversation that needs to be happening right now. You shouldn't be having conversations about, making your workers happy on the exit interview, which happens all the time. You're leaving your job, you're dissatisfied, and now they're asking you why you want to leave. We should be talking about how best we can retain not just nurses, but other healthcare staff as well. And like I said, at the end of my episode, the best thing is to ask your workers, ask people saying, hey, what is it that we can do to keep you here, to keep you happy? What is it that we've overlooked and that we don't know that we're doing? Or is there something else that you may need to make sure that you're successful here? Because I truly believe that if people are happy, especially in healthcare, if we're happy, we're going to work harder and we're going to make sure that we see the best patient outcomes. I tell you, if you're miserable and you're not happy, that's when you see mistakes. That's when there's harm that occurs. Make people happy, you're going to get great workers, and you're going to get the quality of the work will soar through the roof. But you have to ask people what they want in terms of retention.
And if we were to ask that question, what would we hear? Other than everyone wants to be paid more, yes, but right. In addition to that,
I think one of the biggest things is teams, right? I think that team building, that team environment is hugely important. And I think during the pandemic, there's been a lot of stress in terms of mental health, burnout. And I think we need to get back to what does it look like to work and operate in an interprofessional team. And I think that's going to be another huge part in terms of not just giving us online modules and saying, here's the best way to kind of make great teamwork. It's actually about learning with people. So learning with physicians, learning with nurses, learning with your psychiatrist or psychologist or social workers, and doing this in a way that is much more interactive. I know that there's that push for, we got to do more online stuff, but we need to take it a step back because we have been away from people for a long time and we need to learn how to operate with people again.
Great point.
I agree, building teams. The other thing is how to develop skills that are needed to be individually to be developed by the person that wants to continue growing. Let's say, if I have a goal, my goal is to be, CMO of the hospital. Okay, so what are the steps that I need to take in order so I can become that? And what are the skills that I need to accomplish to learn? What's the process for me to learn so I can accomplish that, my dream? I cannot live on a dream, I have to live in action. But how can that be made possible? Like a mentor to guide me. I can do the research, yes, but the person that are already in leadership, they can't. I will suggest to spend some time to, talk about the process or mentor other people that want to follow the steps. They cannot be in leadership forever. The organizations need to continue. Patients need to be taken care of. I think developing, giving those opportunities to the diversity to develop is important.
Great points. So who do you think could be the allies? Obviously we all work with a lot of terrific men, some of them white, who want to help and may not know how. What what could be done to get more allies into the mix?
I don't mind starting with this, if I may. I'm going to cite two books that I think are really good reads. One is called Better Allies, and the other is called Good Guys. And that is by no means a comprehensive list. Those are just two books that I've been through regularly, and the authors have either been on the podcast or they're coming on the podcast.
Mm-hmm.
I think allyship is important. It doesn't get enough attention. And so one solution I would recommend related to that is something called Upstander Training. And I also share the cynicism regarding trainings. But, there's a difference between being a bystander and being an upstander. And there was an article about this in the New England Journal recently by Reshma Jagsi. And she talked about helping people learn how to be upstanders. We all witness comments, behaviors, inappropriateness, unprofessionalism at work. And what do? Well, many people don't know what to do, so they say nothing, they stay silent, they shrink away, they avoid being brought into the situations. Whereas upstander training implies that we actually can teach each other and teach our allies what to say, what to do, how they can support us when they witness these behaviors. It happens all the time. These aren't like isolated incidents. And in fact, there are so many of them that vis-a-vis women leaving, I think what's happened is one of my mentors has said, if instances, behaviors, inappropriateness happened once in a while, once every year, once every 5 years, but it's when they happen so often and in such a cumulative effect that eventually people leave, women leave, women of color leave. And so one solution is upstander training, and that ties into helping to develop our allies.
Great. And then just to close on a more personal level, before we all came on here, Natalia and I were talking about the fact that she is going to be spending her evening tonight speaking to dentists about the what they've been enduring and how they can take better care of themselves. And if I hear the phrase self-care once more, I'm probably going to run screaming from the building. But that cliche aside, I would love to hear more about, I get the walks, I get the yoga, but how do you deal with the very specific stresses and difficulties that you face, every day as women of color, in your work? What keeps you going and keeps you from leaving the healthcare workforce?
For me, it's to find a sense of purpose, of what I'm doing. Mm-hmm. That gives me energy. I'm learning, I think I spoke with you about this, I'm learning to integrate some healthy habits within the work hours. Like I learned from a book, I don't remember the name, that taking, if possible, 20 minutes break. I'm building up 5 by 5 to just do nothing. And that's difficult to do because I'm a doer. I've learned, from my family that I have to be always, running and doing things. But we need to take a break so the mind can calm. And when you have those racing thoughts, worries, you will listen to them, you see them, you hear them, and say, you're part of me, I understand, but I will take care of you later because right now I'm going to do a meditation, a breathing exercise, a walking. Right now, it's not time for me to deal with the emotions. Accepting emotions, of course, you cannot continue running away from the emotions. You cannot control them 100%. Mm-hmm. But, embracing that part of ourselves, and talking to colleagues or peers or friends, and if we need extra help, talking to a psychotherapist. in privacy.
Yeah, it's great advice. Anyone else want to jump in on that?
I smiled because I think, you know, almost everybody I know is actually contemplating potentially a pivot away from healthcare, or what's their exit strategy, or what's their next chapter. But that's not what I'll suggest. There are two things that I think of. One is book related. There's a book by Seth Godin called The Dip. And what he argues is that we need to quit things more and realize, are we doing certain things that it's just a dip in the road and it's going to come back up, in which case we should hold on and continue? Or are we in a cul-de-sac and we're just going to be going around in circles? So quitting more things, saying no to more things, which is contra the messaging we get of always saying yes, but I think we should say no. And by saying no to things that your heart and your head are not in, you actually clear up space and time to really focus on the things that do give you satisfaction, joy, purpose. The other thing, I was lucky enough to write an article with a colleague of mine, Dr. Odera Landry, and it was on mentorship. And the premise of the article was that everybody's taking mentorship and mentoring programs off their plate because it's seen as like a time sink. And we're so stressed, we have too much on our plate, time to take mentorship off. And we flip that and actually argue and suggest that now is the time to mentor, because you develop those valuable relationships. As long as it's a give and take and a duality in terms of the discussion and what each individual gets out of it, or a group of individuals, it actually can be very sustaining and help carry you to a better place if you feel like you're struggling at work.
That's a great point. Amie, you look like you're about to jump in there.
Well, what I'd like to say is it's not actually too empowering, but my eat the cake. Like, I don't know if you can see, I baked some cupcakes, and that's some of the work that I'm doing to keep myself sane. But the other thing is, you know, I really like the saying no, but also saying yes to something that you might have not have thought that you would have seen yourself in, but are seeing yourself in now. So I could tell you, I would have never 5 years ago seen myself in a role of advocacy, or seen myself as a person that can speak out on the behalf of others, or you know, to talk about really challenging issues. And I've fallen in love with the fact that I think it's so important to have these conversations and to advocate, to talk about, you know, anti-racism, to talk about women in healthcare, to talk about mental health. And I find that we're moving into, I guess, this some form of a new generation where women and other people are more empowered to speak about these things. And I'm really excited to see what's going to happen next. And I want to be a part of that movement. So I've said no to things that, you know, I find aren't necessarily worth my time, and yes to doing something that brings me value, or feel that I'm bringing value to the table for others as well.
That's an excellent point. Suzanne, do you want to wrap us up?
Totally agree. I think my final piece here is know your worth. You know, you can definitely walk away from situations in which is no longer benefiting you. I have seen clinicians walking away from the jobs that they thought they should be in to actually from their own practice. And I think Natalia earlier talked about that, was being told, maybe well-intentionally, like, you may not be able to like thrive in this country because of your accent. I was also told in a very well-intentioned way that I have to be mindful that I might not have enough clientele because, you know, Asian Americans do not seek therapy. Turns out that it's all not true. It's just there's not enough of us out there, so we're not seeing that, right? So being able to say that, you know what, I don't have to think things the same way. I just have to know my worth, I know my value, and I can walk away when I don't need to stay in a situation, and I can start new ventures when it fulfills my meaning and my passion.
Wonderful. Well, I just thank you all so much. This has been such a great conversation. We could just, you know, keep it going, but unfortunately we are out of time. So again, thank you all. I really, really appreciate it. And I would like to invite everyone who's watching, since we've been talking a lot about mental health, you may be interested in our next Inquirer Live Health Report, which will be right here on August the 19th. I'll be talking to Dr. Frances Jensen, who is the chair of neurology at Penn Medicine. And she is also the author of a book called The Teenage Brain. And she is just in time for back to school, when I think a lot of us will be wondering how we can help the teenagers in our lives navigate the changing world. I hope that that will be a useful conversation. So again, from the Philadelphia Inquirer, thank you so much for your attention.